Good afternoon. Today we'll discuss ischemic heart failure, emphasizing treatment of the underlying cause, coronary artery disease, rather than solely managing the heart failure syndrome. We'll cover pathophysiology, the role of antiplatelet therapy like aspirin and clopidogrel, key evidence, and a real-world case of severe multivessel disease to illustrate integrated management. Heart failure is the end-stage clinical picture for many upstream issues, but ischemic cardiomyopathy, caused by coronary artery disease, is the most prevalent and carries the worst outlook. While guideline-directed medical therapy, GDMT, effectively counters neurohormonal changes, true management of ischemic HF demands simultaneous treatment of the coronary pathology. Aspirin is often said not to treat heart failure itself, but in ischemic cases, it targets the root ischemic substrate by preventing thrombosis and further myocardial damage. Ischemic heart failure stems from obstructive coronary artery disease, leading to overt or silent infarctions and chronic ischemia that causes fibrosis and adverse remodeling. Progression involves two parallel processes: upstream ischemic injury from plaques, thrombosis, and stenoses, and downstream neurohormonal activation driving further deterioration. Comprehensive therapy must target both, GDMT for remodeling and ischemia-directed interventions for the cause. While obstructive CAD dominates, ischemia ultimately reflects poor oxygen delivery. Hyperviscosity from polycythemia, primary or secondary, impairs coronary flow, especially microvascular, even without critical stenosis, relevant in INOCA. It also promotes thrombosis. Antiplatelets help secondarily, but cause-directed treatment normalizes hematocrit and avoids aggravating factors like excessive diuresis. This highlights treating all upstream oxygen delivery impairments. Low-dose aspirin irreversibly blocks COX-1, reducing thromboxane-mediated platelet aggregation to prevent infarcts and preserve viable tissue. However, it doesn't reverse remodeling or improve ejection fraction. It's not a heart failure drug. A key debate is aspirin's prostaglandin inhibition, potentially blunting renal benefits of ACEI/RNIs. Clopidogrel avoids this, offering a cleaner profile in HF. The prostaglandin conflict questions aspirin's interference with vasodilatory/renal protective effects of GDMT like ARNIs. While low-dose impact is unclear, many clinicians now favor clopidogrel for long-term use in ischemic HF, backed by host exams showing better outcomes. In high-risk anatomy, ensure strong antiplatelet coverage, clopidogrel may better preserve GDMT efficacy. Antiplatelets are mandated for secondary prevention once CAD is confirmed, prior MI, revascularization, etc. They're not indicated in non-ischemic cardiomyopathy or without CAD. Contemporary practice leans toward clopidogrel over aspirin in ischemic HF for strong MI/stroke prevention while theoretically safeguarding renal function and GDMT pillars, especially in advanced cases. Understanding coronary anatomy helps patients appreciate risks. The left main supplies most of the left heart, blockage is critical. LAD, widowmaker, feeds the front, LCX the side/back, RCA the bottom and conduction. Proximal lesions or triple vessel/left main equivalent disease, severe in both LAD and LCX, carry high risk, as in our case. Our illustrative case, severe ischemic cardiomyopathy with EF around 20%, already on solid GDMT pillars. CCTA with FFRCT revealed left main equivalent triple vessel disease, significant stenoses in LM, proximal LAD and LCX, plus RCA involvement, and very high calcium score indicating massive plaque. This confirms chronic ischemia as the driver of low EF. Therapy splits into HF-directed GDMT, RNI for EF/survival, beta blocker, MRA antifibrotic, SGLT2I outcomes, and ischemia-directed, optimized statin for plaque stabilization, target LDL less than 55, and add antiplatelet for secondary prevention. Given left main equivalent disease and low EF, urgent revascularization, often CAB, is key for survival. The patient is on the 4 GDMT pillars plus statin, but missing antiplatelet therapy, now clearly indicated. Add clopidogrel 75 mg for secondary prevention. This complements GDMT without replacing it. We monitor antiplatelets clinically, they prevent clots, but routine platelet function tests don't predict outcomes and aren't advised. Bleeding risk relies on history, prior ulcers, age over 75, concurrent drugs, not labs. Balance prevention with safety. In ischemic heart failure, antiplatelet therapy targets the cause, atherosclerosis, not remodeling. Once CAD is confirmed, secondary prevention is essential. Clopidogrel is increasingly favored. It integrates with GDMT pillars. For high-risk cases like this, prioritize revascularization evaluation, CAB often preferred for survival. Delay ICD to allow EF improvement post-optimization. To summarize, always address upstream ischemia alongside downstream remodeling in ischemic HF. Antiplatelets are vital for secondary prevention, with clopidogrel often preferred. This case shows how integrated care, GDMT plus ischemia treatment, offers the best outcomes. Thank you for your attention. References.